Access to safe, voluntary family planning is a human right. Family planning is central to gender equality and women's empowerment, and it is a key factor in reducing poverty. Yet many women in Kenya who want to avoid pregnancy are not using safe and effective family planning methods. It is a socio-economic conversation. UNFPA, the United Nations Population Fund, provides data which shows that family planning is one of the most cost-effective public health interventions and generates measurable positive change in the life of communities. In this special series, in partnership with FilmAid Kenya and UNFPA, we focus on family planning in Kenya.
Hello, welcome to the One Health Lens podcast, where we have conversations on public health, global health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitao. Today we're having, as always, important guests, but we're having a very big conversation. A conversation I feel we often don't have, or at least when we do, we have it in closed circles. Yet the impact is more than you and me. It's more than just women, because the conversation today is around family planning. Family planning, how it affects, yes, women, households, communities, but how does it affect the economy? So I'll start off by letting our very important guests introduce themselves, not ourselves, and then we'll take it from there. We'll start with you.
Yeah. Thank you, Diana.
Yeah.
My name is Akaco Ekirapa. Yeah. I work with the British High Commission in Nairobi, and I am the health team leader.
Yeah, absolutely.
Thank you, Diana. Yeah. My name is Koronya, and I work with the United Nations Population Fund, UNFPA Kenya Country Office. I'm the Family Planning and Community Security Specialist.
Hey, big words, big words. As I told you, important guests, British High Commission, Head of Health, UNFPA, United Nations for Population Fund. Yeah, important guests. I mean, I'll start off the conversation with first talking about my experience as a medical doctor in one of Kenya's public hospitals, right? And the experience was that, you'd find women coming into the facility and you'd get different age groups, right? You'd get women who are in, say, 30s, 40s, you'd get teenagers, different. And all of them would come with different experiences. So I'll use the example of, say, the married woman. What I found shocking, there are women who'd come in and they'd start off by saying, don't tell my husband. And there was a certain, and it's not that they're shy, it's just that they're saying, you know what, this is a choice that might not be supported, right? But it's a choice that I want to make, right? And it's not that she's saying that I don't want to have children, which tends to be the misconception that family planning is about women who don't want to have children. It's a factor of population. It's all this. But when you speak to her, and she's speaking to me as a doctor or the nurse who's there, she's saying that I already have 5 children. And because of that, she's saying, if I was to have more, how am I going to provide? Right? You have a conversation with, say, the teenager who says, you know what, I want to be safe. I want to ensure that maybe a fate that befell a friend, right, doesn't happen to me. So then when we talk about family planning, it's something that, one, it's dear to my heart, but it's also something that I can relate and say that, you know what, there is an impact, right? So then, in that case, maybe let's even just start off with your experiences of family planning, right? Before we even get to the big conversations, your experience, your views, what has it been like for you to be able to say that you're actually working in family planning? What has been your view? And maybe I start with you, Charity.
Thank you so much, Dr. Diana. Yeah, my experience on family planning, I would say, has been so personal, in the sense that I come from a very big family, where we are children from a polygamous marriage, and I could see as we were growing up, we were many, and it was a challenge even for us to go to school. But that's besides the point. apart from us having the challenge of not even being able to go to school, my parents had to struggle. Only my father was working, my mother was a businesswoman. She had to do anything possible to ensure that they pay for us fees. I had an auntie who was who had so many children, and we didn't know the implications until one time we were told that actually she went blind because of the number of times she had given birth, and we were not able to relate that as we were growing up, because at the end of the day we were like, we could not see the link between getting blind and having children. After all, having children is a blessing. But then as I grew up, I was able to know, oh, so this is what happened. This lady had high blood pressure and she continued giving birth, and she did not see anything wrong with what she was doing, because people believe that then the bigger the family, the better.
Yes.
And so it was like, we are extending our clan.
Yes.
And also besides that, she and the first set of her children were all girls, and she was now out to get a boy. So when she got the last two, she thought that now God has opened the way for all the boys to start coming.
So she needed more.
Exactly.
Yes.
So it's been an issue which really we can relate with, and also the fact that you could hear some of the people saying, oh, people use family planning, are promiscuous, and you are like, what do you mean? So it's something I can relate with from where I've come from and how I've grown up in the rural area before coming to the city.
To the big city.
Yes.
I tell you. I mean, what has been your view? I mean, it doesn't have to be even just your personal experience, because I imagine working in health and working in the High Commission, you get to hear very many stories, right? Is there something that even for you go to work and you say, this is why I'm here? What's that one experience say?
Yes, and thank you for breaking it down. Because I think whenever people hear that we're in family planning, they get scared immediately. I have been called an activist. I have been called all kinds of names. I think people also think you're not, should I say that you're loose? That's
yes,
what
you're promiscuous.
You're promiscuous, yes.
Yep.
And I think during my time, especially because the UK has funded family planning for more than 20 years in Kenya.
Yes.
And like Charity, as a woman, first of all, myself, I think I only really came to understand family planning after the birth of my son, who is now 7 years. And that was the first time I realized that you actually need postpartum family planning. And if you don't have it within the 6 weeks, if you're not prepared, you'll get another child. And I think, one, I look at it from two angles. The challenge that most working women in Kenya are facing, where, as was shown, unlike the previous generation where mostly our fathers were working, or if it's people who had mothers supporting them, one parent was the breadwinner. With this generation, just to make ends meet, both of you have to work. And I think from the perspective of working women, I see women struggling with all kinds of issues, issues of which method to take. At times, we also get very conscious, some of us add weight. Others, you may find you start reacting to one method. Or even, I think as we were discussing earlier, that in some cultures, they don't even allow, if somebody feels the implant on your hand, your husband or your partner will tell you to remove it.
Absolutely.
So I can also relate. We were in the field a few weeks ago, and it was quite heartbreaking because I went to West Pokot. And just to see, the kind of, should I say, the challenges that many of the women go through, because maybe she wants to get family planning but cannot, because either the methods are not there, the commodities are not in stock, or just because of the culture, the husband or the person in charge of the household is expecting 10 children or 12 children. And if you're not able to deliver them, he'll go get another wife. So that for me was really heartbreaking, that especially for many of the young girls who may not get the opportunity to go to school or advance because of early pregnancies. We also saw many cases of child marriages. It's also heartbreaking, even the abuse also in terms of gender-based violence. And we're also here to speak for those women, because we're fortunate to be here on the table.
Yeah.
But we know there are very many women and girls. And also what we saw was the issue about young mothers is also growing. I believe you saw the data from the recent KDHS, where some counties, even like Samburu, have half of the teenagers are pregnant.
Yes.
So I'm seeing we also need to address for this young group who are also mothers. Yes, they're young, but they are mothers. And so we also need to have programs for them. So that is also why we're here. And the UK is also supporting one of the largest family planning programs. It's called DESIP, delivering equitable and sustainable programs for family planning in Kenya, and it's working in 12 counties.
Absolutely. I mean, you know why it's such an important conversation, and even why it's important to have this conversation around how we get the supplies in the country and the support behind it. Because I think we tend to have a lot of conversations around HIV, malaria, TB, right? And you hear that conversation over and over, no matter where you're in Kenya, for sure you've had. You even know who supplies, you never hear about family planning, right? Yet somehow there's the expectation that, as you rightfully said, girls have to go to school, right? Mothers are going to work, right? The people who, I mean, when you're talking about maternal mortality, it's not just a factor of I wanted to have a child and then there was complications. There's more to that, right? As you said, high blood pressure, right? Which then brings me to what the work that United Nations for Population Fund does, UNFPA. What work does it do around family planning, so that we get to understand why it's important, why it's you who's having this conversation with us here?
Yes. UNFPA, the work we do on family planning, first and foremost, we actually support the government of Kenya to build the capacity for healthcare workers on family planning methods, that is to provide the services. Number two, we also support the government to procure the commodities, the family planning methods, and that's why we see if there are no commodities, there's no program. Because if the programs are not there, what will the people be getting? We also support the government to have like a South-to-South collaboration and lesson learning from across other countries on specific areas. And apart from that, we also support the government when it comes to evidence generation. For example, if there's a new method, like for example, to do some evidence, to even generate evidence before we can start even programming. Sorry, we don't evidence for programming.
Exactly,
to help us in programming. And also we support the government in terms of advocacy for specific areas. So this comes, UNFPA collaborates with a number of partners at the global level and also at the country level. And among our collaborators is the British High Commission and of the British government, where we collaborate globally. First, at the global level, UNFPA gets the support from various partners, USAID and the UK government, where they fund the commodities at that level. Through the program called the UNFPA Supplies, which is the UNFPA Family Planning Flagship Program. So they give us commodities at that global level, which now triggers down to specific countries. And you see now the British government has been quite good to Kenya and to UNFPA Kenya, that also besides getting us, giving us commodities at the global level, they are also giving us commodities at the country level. And this is a collaboration we have had, which is really, really very useful to the Kenyans, because at the end of the day, the woman in Meru, in Marakwet, does not know how these commodities come.
Exactly.
And so it's really a matter of appreciating the collaboration we have had with the British High Commission in terms of ensuring that the commodities are received at the last mile.
Yeah.
I
mean, it's I'm imagining as the listener on the other end, it might sound as if it's very technical terms, programs, whatnot, right? But I like the last part where you said is ensuring that the mother, the Diana who is in West Pokot, gets the product, right? There's a lot of technicality, but it's ensuring that they get the product, right?
Yes.
And it's important to also emphasize that because governments do have competing priorities, right? And I'm saying this because I've once had people saying that, you know what, there's different agendas, this is foreign agenda and whatnot. And I remember thinking to myself at some point, again, with this experience of working in a hospital that, and other colleagues, whereby if you were to think of, actually, let's even talk about your own household, right? If you're in your own household and you have to take the kids to school, you have to pick up, you have to do errands, you have to do multiple things. The day someone comes and says, I'm willing to at least pick up the kids for you since we are neighbors, and then we drop off, there's a certain relief that comes from that.
Yes.
And that's a good example in terms of why the collaboration is important.
Yes.
You are already going to go pick up the kids. People need this family planning commodities. People need contraceptives for different reasons, right? But it's not all going to be done by one person. That's why the partnership is important.
Sure.
That's why then it becomes important for the High Commission to come in, right? So then talking about the collaboration, right? Maybe expound on that, because I saw a few sort of headlines around this shipment that has come in. There are several initiatives that you have been able to at least support on. Maybe you could elaborate on what some of those initiatives are. Yes.
Yes, thank you, Diana. And I could first start off with a wider partnership.
Yes.
And yes, as you mentioned, we are government. So we have a bilateral MOU with the government of Kenya.
Yes.
And our wider health partnership looks at strengthening health, human resources for health. And you may have also seen our work sending nurses for work in the UK and also to get sustainable jobs. So for that, so far we have sent up around 300 nurses to the UK. And then we also have our focus on universal health coverage, which is equally important to both governments. And the UK is also known in terms of globally just for best practices in terms of how the National Health Service has operated. Because in the UK, as a public person, you are able to walk into a public health facility and get services. And so for Kenya, we're also trying to model the same, as you know now with the UHC reforms. And a key part of that is also family planning services. And when you look at the wider approach around sexual reproductive health and rights, where many governments have also signed up towards the Sustainable Development Goals for 2030. And key of that is we also have family planning targets. And for Kenya, Kenya has always been committed towards making modern methods accessible for all Kenyans. And for us, through our programming, we particularly focus on the most marginalized populations in Kenya. And so you'll see our programs, we tend to reach the very far or very marginalized groups. So those are either northeastern Kenya or around western and also the coast. We also focus on persons with disabilities because for the UK, we take a very keen approach in terms of including all populations, including forgotten populations. And particularly have a keen focus on women and girls. And so part of our work we're also doing with UNFPA is through the DESIP program that I mentioned. And that is also trying to see how to move towards sustainability. Because as I mentioned earlier, we have invested for almost 30 years now in just the maternal space and also family planning. And so as Kenya is also progressing as a low middle income country, many of the donors are also moving towards sustainability. So in line with that, our program has also focused on also empowering the government of Kenya, both at national and county governments. We have supported the government to develop reproductive health policy that was launched in 2022. We have also developed very many strategies, including the total market approach. We have policies, guidelines, and you may have also heard in Kenya we have the best policies.
We do.
Yes.
We do.
People come even to learn from us.
I
They
tell
come
you.
to learn. So
Policies and strategies.
what we're now doing is now translating that to the ground, like you said, because health is now devolved. We are now moving to see how do we move these best practices from the national and now operate at the county. And I believe you also are beneficiary from that.
Absolutely.
And you attended media training.
Yes, absolutely.
And so we're happy to see a direct product of our support and collaboration with you.
Absolutely.
Yes, but we have very many partners. To mention also Population Services Kenya is the lead consortium partner for DESIP. We've also worked with Options Consulting. We've had very many interactions also with National Control, Population Development and CPD. And continue to support many of our partners in the maternal and child health space.
Absolutely. You know, Charity, your job doesn't sound as if it's easy at all.
It's not.
It's not.
Yeah.
It's not. Because, I mean, between managing, the partners, right?
Yes.
Then I'm imagining you're working with government.
Yes.
You still have to work with communities.
Yes.
People like us also.
Yes.
I mean, it's not easy.
It's not.
It's not, right?
True. Yeah.
So then I will ask, I mean, and I know at some point I'd want, say, the Ministry of Health to come on board and we have a conversation with them, right? But I'll ask you for now, right? Around the family planning program in Kenya, right? How is it structured first nationally or per county, so that you tell us what that program looks like, right? And I know you're not the expert, but maybe to give us an idea, so that when we're talking about the Diana, I will say again the Diana in West Pokot, right? For me to get my product, right? What typically happens, because we now have an overview that these are the partners who are supporting, right? What happens, because I know there's an element of, from a hospital perspective, we place orders. I know there's something happening in procurement. It goes to KEMSA, it comes to us as we administer, right? But maybe it's important to understand why it is so important to have so many partners, because it's not a matter of, you're not shopping. It's not you going to a supermarket, picking bread, and then you put it in a shopping basket and you pay, right? Yeah. So that program is complex. You're dealing with multiple people. Can you just give us an overview of what that family planning program looks like, so that then at the back of our minds, as we're talking about this, we know it's not an easy task. Yeah. What does that look like?
So thank you, Diana. So there is the National Family Planning Program, which is run by the Ministry of Health. And as we have agreed, I'm not talking on behalf of the Ministry of Health.
You're not talking on behalf.
Yes, but now how the program is structured is that at the national level, there are partners. And these partners, they play specific roles. And for the time being, I'll talk so much on what UNFPA does with the Ministry of Health, and how others come in. So for that commodity to reach the Diana in West Pokot, so many things take place in between. First, there is the focusing and the quantification of the commodities required. And this is coordinated by the Ministry of Health. UNFPA supports the focusing and quantification. In this process, the Ministry of Health brings various partners, private sector, CMBUs, and anybody who is in family planning program. And we sit down together and see what commodities are required based on consumption data for the last 1 year or 2 years.
And then just to even interrupt you, because I know we're using the word commodities a lot.
Family planning methods, yes.
Okay, so you've understood in this area, this is the amount that's required.
Yes.
Okay.
So how much family planning methods are required and which type. So once we sit down and know we require nationally this number of family planning, let's say the pills, the implants, or the family planning methods, once we know what is required, now the ministry together with the partners, including UNFPA, sits down and say, so how much is the government going to commit for these family planning methods in the next 2 years? We get the commitment from the government. Then they come, UNFPA, how much are you going to support? let's say USID, FCDU, of course through UNFPA, how much are you going to support? So they come up with like a table showing these are the number of these are the methods required, and this is the total cost per year. This is what is available. And so based on what is available, the commitment made by each partner, then now we procure. We procure the methods, and UNFPA has got an added advantage because they are all the economy of scale. They are procuring globally, and so we are able to procure so much at less price. Once the family planning methods are ready, we work with our procurement branch for them to be shipped to Kenya. Once they arrive now, we alert the Ministry of Health. These the commodities which the family planning methods required through UNFPA support are arriving this time. And then we plan, and they say, fine, take them to KEMSA. We ask KEMSA, we are bringing the family planning methods. We want to know where to deliver.
Yes.
Then they are delivered to KEMSA. Now, once they reach in KEMSA, now KEMSA is able to issue or distribute based on the pool system from each facility and by county. And UNFPA, with the support from the British government, we've supported the government to have a national logistic management information system, a system which is able to really support the county to get the family planning methods they need based on consumption. So somebody sitting in KEMSA can see when Charity from West Pokot is ordering the pills, our utilization data shows this and this, then they are given. So based on that, once the commodities now are distributed, again, we don't just sit down. We want to know what British High Commission and others supported UNFPA, have they reached the intended beneficiary?
I was coming to ask that question, yes.
Yes. So we plan again and say, okay, every month we ask KEMSA, can you please give us a status report, distribution report, where we get a report showing out of the total family planning methods procured, this went to Meru, this went to Embu, this went, and the balance is this.
Yes.
Okay. Then we also ask, apart from what UNFPA supported, can you give us a national overview? Other family planning methods supported by other partners, USID, or maybe Chai, or Bill and Melinda Gates. Can we know what is the funding gap? And they're able to tell us these are the gaps.
Yes.
Now, after that, we sit and say, now we see you have distributed the family planning methods for 6 months or 8 months. We randomly pick a county or a facility based on 2 criteria, although not so much random, because we look at the value of the family planning methods which were sent to that county and the facility and when and the consumption. So we plan with the Ministry of Health and the county leadership to visit that facility. And when we go, we check the documentation. How much did you receive from KEMSA? How much have you been able to dispense? What are the records? We look at how the commodities are stored, and we look also at the general environment. And we look at the records. Yes, you received this number of implants. We look at your register. We are able to see, and Diana from West Pokot was able to get this implant. So we are happy that at least the intended beneficiary has gotten what was meant for them. Yes.
Absolutely. I mean, what I like about that, accountability.
Yes.
Accountability, because it's not just a factor of funding support, it's not just a factor of they have been supplied, procured and supplied, right? There's follow-up, right?
Yes.
So that then again, it's about the Diana in now Bungoma or Diana in wherever has gotten that product, right?
Yes.
And again, we've agreed it's a factor of we are helping each other. It is not one agenda. It is, we have competing priorities. There's so many things under healthcare that we need support, like anything else, right? Now, I'm going to ask a very tough question.
You saved it for me.
I saved it for you.
Yes.
It's because, and let me speak as a layman. Let me not speak as someone who's at least read what's been in the headlines, who hasn't had whispers, none of that, right? It's not cheap, right? Funding, no matter what it is, whether it's family planning, whether it's just maternal child health, just get anything, right? Even a home itself, it's not cheap. The world is changing. Our economy is growing. We're moving to low middle income. We're moving up. Things are changing, right? So even in terms of funding and that outlook, it's definitely changing, right? And you sit at least in some of these conversations whereby there's going to be an impact over time, right? Now, and perhaps I'm struggling with the words because I don't want to put you on the spot. You cannot speak on behalf. Yes. You cannot speak on behalf. But maybe let's talk about the progress you have seen. Because as you said, these initiatives have been going on for a while, right? Have you seen at least progress whereby you can say as a country, we're moving towards a direction whereby we can sustain, we can move away from too much support? Have you seen progress? And what does that look like, right? Because again, we've said most of this partnership, it's collaboration, but there's accountability as well, right? So we're not saying that you're continuously going to get funding, right? But have you seen progress? Maybe that's the question. Have you seen progress? What does it look like?
Yes, and we were discussing this earlier with you, that Kenya is actually known as an exemplar country. And what that means in our family planning circles is that we have been recognized even globally and won awards just for the progress we have made in making family planning methods accessible, even to Wanjiko, deep in Samburu or Mandera. And the fact that we have also signed up the global commitments that I mentioned earlier. So one of them is the Family Planning 2030. They're also known as FP 2030, where Kenya had also committed to what we call 64% modern contraceptive prevalence rate, which means that for every 10 women, 6 of them will have access to a modern type of family planning method. It is good because we have come from a very long way. Over the past 20 years, Charity will tell you, we have come from very far, probably even doubling our, what we call our modern contraceptive prevalence rate. And also the fact that we can have open conversations like this. There was a time we were stigmatized for even having these conversations.
Absolutely.
Secondly, on the policy level, with the donors and development partners, we have also come into an agreement, a memorandum of understanding between the government and development partners. And the government has committed to paying 100% of family planning commodities by 2026. Okay. So that is great commitment. And the MOU started on what we call a matched funding. So you gradually pull out your funds. So I believe it started off as 1-to-1, then you go down 1 to 0.5, then you scale down like that. And yes, we have had some setbacks, of course, with the fiscal pressures. However, we've been in discussions lately with the ministry where we've seen commitments for the next financial year. So the gap, last year we had a funding gap of about 50% for the commodities, but we believe that it will become smaller as we continue conversations. And then also, I think in line with your question, you asked about the report you saw with us, I believe it was 2 weeks ago, where we were also in KEMSA and showing our donation for the, I'll call it Sayana Press, or EASY, which is DMPA-SC. And this is also some of the innovation that we're also doing for the UK to bring methods that are easy to use. Sayana Press is self-injectable. And we have also trained the ministry and our partners on the guidelines. Other countries, Sayana Press is actually administered to people to do self-injectable. But in Kenya, you need a health worker to do it for you. And so the benefit of these commodities is that they can be sent to very far areas. And, they're not even affected by temperature. They're not... So it's a very easy commodity. And then the person can switch methods easily because it's more of a short term.
Yeah.
And if they feel like they need to move to more long-term method, they have the choice to do the same.
Absolutely.
Yeah.
I mean, we've had a guest in the studio before who said this, right, around working with underserved communities or even facilities, because she's a gynecologist, and she's saying that we underestimate, forget what product, we underestimate the difference around whether this product can be refrigerated or not. Simple things as how complicated it is to use something will determine if it will be used, if it will be purchased, if it will be ordered, right? And so then maybe as we're sort of winding up and just talking about some of that innovation, right? You've talked about products that people could administer on their own, because part of that challenge tends to be the fact that I have to first hide that I'm going to a facility to get a product. That becomes a barrier, right? The fact that then potentially, yes, if I get it for free, well and good. If I now have to go to a private facility, it becomes a different barrier. The barrier that, as you said, at some point, if my husband can feel it, if my partner, whoever it is, if people hear, if they see me, all those are barriers, right? And it has not been the easiest conversation, because over time, as you said again, it's been, if you're promiscuous, that's why you have a contraceptive. Why do you have a condom? Even let's just start there, right? The fact that there are women who say their husbands left them because what? They're in family planning. There are communities that believe that, you know what, population control, they're trying to, limit our numbers for voting and all this. There's a lot of talk, and we're going to have some of those conversations, right? But in terms of just innovation that has happened, and this is just also futuristic, right? What have you seen from the UNFPA side? Because I know you mentioned, Kemsa, you talked about capacity, right? What have you seen in terms of just the adoption? Leave the Dianas, right? Because Diana will only get it if you're having goodwill, if you're having more people speak up, right? If you're having progressive conversations, right? So, and I mean, the shipment lasts the 2 weeks, right? That means then there is more interest perhaps in a certain method, right? But is it true that she talked about progression in terms of just policy, but from a consumption, and again, you cannot speak for government procurement, but have you seen at least progression from the people who administer facilities? Have you seen an uptick in terms of just the products? What's been the development or the progression you have seen from your end?
Thank you, Diana. Again, there has been both progress, but there are also challenges.
Yes.
Progress in that these days, like Akaco said, people can talk publicly about family planning without fear or stigma. But there are some specific communities who still believe that family planning is against their religion.
Yes.
And if you look at the modern contraceptive prevalence rate in the countries, you find that some counties like Kirinyaga, Nyeri, Meru, they are quite high, around 70 and above. But you look at counties like Garissa, the northeastern Asal areas, Garissa, Isiolo, and all that, they are as low as 2 to 5%. Because there is that link between family planning and religion. It's against our religion. There's still a lot of myths and misconception that family planning is going to affect the health of the woman, that the woman using family planning is going to be promiscuous. Once she's using this method, she can sleep with another man and she can't conceive. Then there's the belief that also that the family planning is not good for a woman. So there are so many myths and misconceptions, and included with the religion. But also besides that, also there is also the service providers gaps, in that a number of them also, I'm not in a position to give specific method. And this is also based on individual biases. Others is because also they just don't want to do tiring work. They just want what is easy for them. That's why we find that methods like implants, not so many service providers want to do that.
Yes.
And so you find that provider bias becomes also a challenge, because a provider wants to do what is very easy for them to do, and yes, they'll cancel the clients, but at the end of the day, they will end up giving the clients based on what they find convenient.
Yes.
So there are those challenges, and also this the issue of men be thinking that family planning is for women.
Yes.
What business do I have with family planning?
Absolutely.
So you find that the things like permanent methods, you find that if you look at the World Vasectomy Day, you can count how many men will be out there to say, I'm a champion on vasectomy. When it comes to tube ligation, very few women, or even if they can sign, very few men would want their wives to
come up and say.
Exactly.
Yeah, exactly.
And because also there's belief that, if she has had a tube ligation, she's going to be cold, sexually active, men are going to be impotent. So there's all those misconceptions and individual biases and gender stereotypes which are really affecting the uptake. Yeah.
Okay. I mean, we could go on and on. We could. But I want to conclude with, just as we started, with your views, right? Because it always comes back to, we're not having this conversation for the sake of having it, right?
Sure.
We're having this conversation for a certain impact, because either you, a family member, there's someone you know who's a beneficiary, there's people we know who then, it's not a factor of family planning is a nice to have, right? It's something that, as you say, Charity, there's a woman out there who got complications that could have been avoided. There are people dying. It is not because people are being promiscuous. It's not that, right? So then, as we conclude, and I'll ask, it could be anything, right? What's your call to action, right? Because again, we're lucky and privileged that we are able to have this conversation, and it's a conversation I hope we continue having, because we have moved past the stage whereby we do not even go ask for a condom, right?
Yes.
No, the way people
supermarket,
in the supermarket, right? We have made progress. We really have. And it's encouraging whenever you hear even men coming out, even the one who's coming out to say, I've had vasectomy. We've made progress, right? But what's your call to action, right? Because you've had multiple conversations. You engage with different people. What would be your call to action? Charity.
Yes.
And by the way, you look very lovely.
Thank you.
Hey, I've seen you. Hey, was it just for me?
Yes.
What's your call to action?
Thank you. So my call to action would be first to the government.
Yes.
The government of Kenya knows the role the family planning plays in the country. Yeah. It is to ensure that everybody knows that the benefit of family planning are so wide that a family planning is actually a socio-economic driver. And if it is well practiced, we can go too far. Because when we practice family planning, the issue of the job opportunities will not be a challenge. Housing, all those related challenges. Yes. And also when it comes to the issue of the health, the health of the woman. Yes. Once she's healthy, she will be able to be more productive in the family, at her workplace. Yes. Like now, I believe I'm productive because I was able to space my children.
This is true.
And I was able now to go to work. Yeah. I can be able to move around without feeling like, I'm leaving a very young child and I'm not struggling because I give birth to the number of children I'm able to bring up. So it is really to call for the government to support the program in terms of ensuring that the family planning methods and supplies required are available 100% with the government support. Because as a low middle income country, as Akaco said, donors are here to to withdraw at a certain point. So the government needs to put things in place to ensure that by the time the donors are saying we are leaving, then the government is 100% funding like they used to do before on devolution.
No, absolutely.
Yes.
Absolutely. I got you. Call to action.
Yes. We have been here and we will continue speaking.
Yeah.
I don't believe our voices will be silent. My call is also to like-minded partners and also donors also from both public and private sector for us to be more coordinated in our approach. We need to remember also the Wanjiko, the hidden Wanjiko out there, and particularly our people living with disabilities. What our work has shown us is a lot of Kenyans are really suffering, and we would really hate to see all our investment that has been made in this space being lost. And so my call is also for our champions out there, our male allies, also for our religious leaders, our youth, and for all who support not just family planning but maternal child health, because we look at the wider reproductive health space. And for Kenya to continue remain shining on the map as an exemplar country.
Absolutely. I mean, as we said, Kenya is, well, good policies. We have good policies, right? We do. I think it goes back to, and I like first one, you've both given your own personal experiences, right? But I think if we were to think about it and continue thinking about it around, it's not an agenda that has been forced upon us. If you're to think about it from that angle, then it's not about polygamy. It is not about promiscuity. It's not about it's a women's agenda. It is, as a country, if we were to prosper, right, we need some planning around things. And part of that, hence family planning, right? We need that. So that it's not a conversation that we only whisper or we say, no, we don't want to talk about it here, right? That's what family planning is about, right? And I'm hoping that you're going to invite us, as always.
To roll out the training tiki.
Training, of course. No, because we're here. It's not just being a medical doctor. It's not just being a woman. It's being a Kenyan, right? And that's why we're having this conversation. Thank you so much, ladies, for coming.
Yes, we're looking forward to the next one.
Absolutely. Thank you so much. And thank you to the team. I tell you, the team, I've seen some of the work that you're doing. Thank you. I might not mention names, but tell them thank you.
Yeah, thank you.
Asante.
Thank you, Diana, also. You have been very instrumental in finishing the media and advocacy toolkit. To be very honest, your technical inputs and guidance.
It is something that I know the importance. That's why it's important to have this conversation. Thank you so much for joining us on the One Health Lens podcast, and we'll see you next time. Thank you.